right, well, welcome everybody. Words are very important, and this presentation of a very unique implementation is called recovery-oriented. You don't often hear that phrase in relation to opioid treatment programs, which is the name that we now use for what has been called methadone maintenance programs.
I am so sorry to interrupt right now, but we're seeing your monitor on the left rather than the one on the right, which is the full screen. I think the easiest way to switch this will be to hit that button that says End Slideshow. It's toward the upper left of your screen. That's the one.
Okay.
And then go back to your WebEx window. And when you hit Share Screen this time, choose Monitor 2.
We'll get to this really, but what I'm going to talk about here is a unique project where we are looking at moving opioid treatment programs into providing ASAM Level 1 and ASAM Level 2 outpatient services. So we're moving from a model where the program provides and functions as the focus to a more individualized approach where we try and look at what client needs are. Like it takes a village to raise children, it takes a village to do these change projects in real time. And here at IRETA, the project lead is David Reason, who's our Director of Clinical Operations. Our research and evaluation team led by Dr. Dawn Lindsay is involved. And we have a medical advisor, Dr. Peter Cohen, and a quality assurance person, Susan Bergman, who's helping us to make sure that we're hitting the marks that we are supposed to be hitting. So what I'd like to do is start and tell you a little bit about OTPs. There are several very effective medications that are approved to treat opioid addiction. They're effective. This is not a lecture or seminar or webinar on the medications. We're going to be focusing on the pieces that are missing. But the medications are effective. They're empirically validated. But they're really only one component of comprehensive therapeutic program. Right now, we're hearing in our opioid epidemic that we really need to expand the use of these effective medications, and that is exactly correct. The issue is, are we going to expand and make this available in the way that we have in the past? That's what's of a concern to us and why we started this project. We have been looking for a payer, a sponsor, and clinics for 3.5 years to try this. And it took a while because, in fact, to do this change project is a significant departure from the way things normally are done. And that required a payer to be able to make some changes in how reimbursement was set for methadone. And I'll talk more about that. But medication is only one part of it. They're safe, they're effective when used as they are meant to be used, and they help stabilize people and, in fact, make them available for the potential to enter into a recovery. What's missing right now are clinical and counseling services. We've not done a very good job for patients who come into OTPs at providing a full array of services. And I am, in fact, not being critical. I am reflecting and offering the observation that we haven't significantly changed to make medication a tool. We organize the program and the intervention around the medication instead of around the patient. And what's missing is an individualized clinical counseling services approach. So in current OTPs, what we used to call methadone maintenance, by statute and accreditation requirements, the clinical services are 8 urine tests per year, and it's really 2 hours of clinical counseling services a month. Our project is in Pennsylvania, and the Pennsylvania regulations call for 2.5 hours of clinical or counseling services a month. These are set by statute. OTPs are required to be accredited, and the accreditation standards are the ones set by statute and regulation for 8 urines a year and 2 hours of clinical counseling services a month. Again, Pennsylvania has more stringent requirements of 2.5 hours of services a month. OTPs dispense methadone. Our project is in programs and sites that dispense only methadone. So we're not working right now with buprenorphine patients in getting clinical services. I think we'll evolve to that. But right now, it's how do you improve the clinical quality in OTPs? The fact is that methadone has become a synonym for a level of care. In fact, that's how it's reimbursed. And everyone who comes to a methadone program essentially gets the same frequency and intensity of clinical services. In other words, you come in and get what our program offers. We don't necessarily provide a more frequent and intense clinical service if that's what you need. That's the problem. If we expand OTPs, and we should, to match the opioid epidemic, to try and make these medications, and this medication in particular, more available, we may not be providing significant clinical services. As a level of care, an opioid treatment program does have a certain administrative elegance. And having been a bureaucrat and an administrator and someone who regulated the industry, you know, there's a certain elegance to being able to do things. The operations for medication dispensing are regulated, they're standardized, and it's really easy to replicate. You are able to get a computerized dispenser. Doses are kept very precisely, the records are very precise. And the way to do the medication service and the medical service is actually very, very well established. You can repeat it. And in fact, in companies that now have included OTPs in their continuum of care across the United States, those companies basically are having a manual that replicates their procedures across the whole country. So in medication dispensing, it's heavily regulated and really standardized. Even the clinical programming, such as it is offered in standardized thematic groups, and it meets accreditation requirements for HIV education, orientation groups, tapering groups. They're pretty much open groups, meaning that people sign up for the group and go to attend the group. And since there's a requirement for 2 hours of face-to-face clinical time a month, attendance at one of these groups has made you fulfill up to 1/2 of that requirement. The treatment plans are standardized and virtually identical for each client. This is sort of one of the benefits, if you would, of having computers and electronic records, because you can have a standardized electronic database and a pull-down menu and have treatment plans that are pretty much standard. And that's what happens. It's virtually identical for each client. It's coming in daily, it's attending sessions, it's going to an orientation group, it's coming to scheduled urines. It's the same. Counseling staff basically function as case management and record keepers. It simplifies the scope of practice. Even for groups, there's standardized formats and manuals and handouts, and it takes staff away from actually counseling services. But you hire to the needs of the program. So as a level of care, there's a certain amount of simplicity and elegance to this, and it's easily replicated. Finally, as a level of care with really limited service requirements, an OTP can be funded by a flat per week service fee that includes all the medical services, meaning an assessment by the physician, the nursing staff, the medication itself, and the counseling staff who are providing, in Pennsylvania, 2.5 hours a month, or everywhere else, 2 hours a month. So you're reimbursed a flat fee for every patient that's in your clinic. But it turns out this is sort of a perverse incentive. What I mean is, you really provide no more service that meets the statutory and accreditation requirements. And when DATA 2000, which created an accreditation requirement, that's a federal law, that created a requirement for accreditation, the thinking at the time for the proponents of this statute and then the regulations was that this was going to standardize treatment in OTPs. And in fact, the name was changed from methadone maintenance to opioid treatment programs then, to try and make sure that what happened was less focus on just the medication and more focus on the treatment. And the idea was that it was going to create a floor. Turns out it's just the opposite. It's created a ceiling. And the reason is, if you can constrain expenses, you can maximize profit. So if you're doing to the letter what's required, you have a standardized set of expenses, and you know what your reimbursement is, and you can predict very reliably based on the population, what your revenue stream is going to be. That's kind of a perverse incentive. It turned out not to be the floor, but the ceiling. So today, what's the result of setting up a program like this? Well, the national completion rates for OTPs hover between 11 and 14%. This is data from the federal government, TEDS data, Treatment Episode Data Set. And there are inherent problems with that because it measures only at intake and at discharge. There's a lot of things that happen in between, but nonetheless, this is one of the most reliable measures of discharge status for people who are in OTPs. And it's been a consistent data set since about 1971. So it's got some ability to offer comparisons. Retention is also dropping. The average days in treatment across the country have gone down. And it seems like, from qualitative interviews and not from the quantitative data, that clients enter OTPs more for a respite and get a timeout, and then they move on. It's getting hard out there. They're physically compromised. They're emotionally exhausted, and the lifestyle is starting to get to them. And going into an OTP offers an opportunity for stabilization. Again, the medication's very effective when used in the right way, and a certain amount of structure. In that way, OTPs are used more as a harm reduction strategy, really not a recovery orientation. And if we're looking at recovery, it's a hard thing for someone entering into an OTP to get that message, because the needs of the medication, not the client, seem to organize the program. Again, sometimes you get the results you're designed to get, and I think that's what we have here. When these programs started, we never faced the epidemic that we face right now and the complexities that people bring. The medication was going to stabilize people who otherwise would be unable to make it, and with some supportive services, things would be fine. That's a harm reduction orientation in place now, but there's an alternative and competing view, and that's the one that drives this project, this quality improvement project. It's a recovery orientation, and that shifts the focus from program-based care to client-based care. The theoretical underpinnings to this approach in OTPs is a monograph that was written called Recovery-Oriented Methadone Maintenance. It was written by Bill White and Lisa Major-Torres, and it was sponsored by IRETA as an ATTC, sponsored by the Great Lakes ATTC, as well as the Philadelphia Department of Behavioral Health and Intellectual Disabilities. And it provided a framework in arguing persuasively from literature that medication in no way takes away the need and the necessity of a recovery orientation. And you shift to what the needs of the individual are, something that's very familiar in other parts of the addiction field and other parts of healthcare. So medications are important, but they're not the sole focus of OTP treatment. They are a tool. And again, we're speaking right now about methadone. It really holds the same for using Vivitrol and for using buprenorphine. But our test sites are OTPs that are exclusively using methadone. So in order to shift from a program focus where basically everybody gets the same thing to a clinical recovery orientation, you really need to have a comprehensive clinical needs assessment. And that's not something that routinely happens. It doesn't mean that programs don't want to do it or can't do it. It's that it doesn't make a difference in the service that they would provide. You also need to use standardized placement criteria. Here is where a system like the ASAM criteria come in, the American Society of Addiction Medicine. If you do a comprehensive needs assessment, you should be able to match someone to a level of care in an intensity. So in the OTP project, we're looking at installing with the programs a level 1 outpatient service, and we'll talk more about what that means. And again, we'll have Pennsylvania as an example right now. and a level 2 intensive outpatient service. The reason is the same reason you would do it in any other clinic. You want to be able to get somebody what they need, not simply what you do. So it's matching to the most appropriate level of care, not a new concept. You know, matching is the preferential assignment to a condition because you have a theoretical basis for understanding that that would maximize the chance of a good outcome. And that's what we're trying to do here. We're trying to shift from a program to a clinical focus, a recovery focus. So that's what a recovery orientation means. So it took us 3.5 years to be able to find a payer who would be agreeable to doing this. And the reason it took so long is that you had to unbundle services from payment. So there was a level of care payment. Remember, OTPs, the medication, methadone, was thought of as a level of care, and there was a weekly fee. Well, in order to do this project and test it out, you needed to have a separate fee for medication and then services that were billed, like individual and outpatient services on level 1, that were billed just as they would be in any other clinic. So this project found that payer in Western Pennsylvania, Southwest Behavioral Health Management Incorporated. So this project right now is running in Western Pennsylvania. Southwest Behavioral Health, along with the county authorities, put out an invitation to existing OTPs describing this project. The reason, the rationale behind it, much as we spoke of already, as well as a little detail about what it would entail. These are 2-year projects at each site. So 6 OTPs have been selected. 2 are underway. The initial one is into its 18th month of a 2-year project. The second one is in the 3rd month of a 2-year project. We've now reached the point where we'll be bringing on a new clinic, a new site, every 3 to 4 months. So as we finish the first one, as we're finishing the first one, we started a second. A third one will start when the first one's gone. So at any one time, we'll be working with 4 different programs ultimately over a course of 2 years each. And each one will be at a different phase. So here's how we do things. We spend a lot of time before we ever go on site. We look at and analyze outcome and performance data for the prior 2 years before we begin. So it's really the past 2 years, but the prior 2 years. We take a look at policies and procedures in the sense of how does this operate? This is a consultation, not training model. The reason it takes 2 years is that we are actually on site when we begin 2 to 3 days a week, and I'll explain more about what that is. We attend staff meetings. We get the staff an opportunity to not just meet us, but us to understand the dynamics. We review clinical record keeping. We observe every clinical staff in conducting individual sessions and conducting group sessions. The reason is not just so that people would get comfortable with us and that we can demonstrate that we know what we're doing. All that is true. But the other piece of it is this is a consultation. It's not training. We need to start where people are. It's just like counseling 101. Start where your client is. We start where the program is. There are strengths in every one of these programs, and that's what we emphasize, what the strengths are. So it will take us 3 to 4 months before we ever start installing, and that's how we talk about it, installing the clinical services. So we've been working with one site for the past 18 months. And here's what some of our due diligence before we began showed us. The patient outcomes were at the low end of the national averages. And frankly, the program knew that. They are a courageous group coming forward to be the first ones, and they are to be commended. It's Foundations Medical Services. And they are part of the Pyramid Healthcare Corporation, and they are terrific. And we have a wonderful working relationship with them. And they were very fearless. And that's what we really wanted to have, people who were willing to have a critical look at what they've done. But the outcomes are at the low end of the national average. There was no particular clinical orientation. Okay, what I mean is not necessarily a recovery versus a risk, a harm reduction approach or a risk management approach. That's not what I mean. I mean our theory of intervention and change is behavioral therapy. It is cognitive behavioral therapy. It is relapse prevention. That is what I meant. It was essentially very eclectic with no particular orientation. So there wasn't a recovery orientation. The groups are, as we expected, they're open, thematic, and disconnected to a theory of change. What I mean is that there will be a group that is talking, that is going to meet, and that's going to talk about women's issues. And anybody can sign up for that group. It'll meet on Wednesday, once a month, this particular Wednesday, and you can sign up. So there could be 10 people there, there could be 20 people. And as these things go, groups are better attended towards the end of the month when there's a need to get that 2.5 hours that are required, 2.5 hours of clinical services. But the group is essentially a psychoeducational group. Here's something that is the strength. The clinical staff really were good. They had really, really good interviewing skills, and they could really engage with clients, but they couldn't do their job. They couldn't do the job that they went to school to do. So the program design really limited what they were able to do. And that's something that we found in our second site too, but this is talking about the first site. So the clinical staff were really enthusiastic about this. So here's what we did. Part of the time spent with staff was to hear what some of their concerns would be. And among the concerns for the staff and the program leadership, and again, this is why I think they were really courageous to want to be the first ones. They were fearful that as more was required of clients, they would lose people. But here's what we did. We asked, what would be the orientation, the clinical orientation that you would like to have here? And we went over some of the ideas and theories of change that other programs use typically. And program leadership said, we want to use CBT. So we did introduction to CBT. We also did an introduction to group dynamics and group therapy concepts. Again, the groups that people had been used to running were really psychoeducational groups, and we're not process groups. And they were not closed groups, closed in the sense that it met every week at the same time with the same therapist. Yes, new people could be introduced, but there was a planful introduction. You didn't pop in and pop out of the group. There was a consistency to it, and you built a group process. Then we moved on to more advanced training and application in the use of CBT. Now, I said this was not a training project, and I did mean that. We did all of this on site at the clinic. We are testing that it's more efficient but also more effective that consultation and help occurs in the space that people work, in the space where they learn the best is on their own cases. So we did all of this on site with IRETA staff, primarily David Reason. And we introduced case consultation as quality assurance, setting aside time that you were going to be able to talk about cases, difficult cases, how to frame it in CBT, what's the treatment plan supposed to look like, how do you respond to clients when it's not going as well, when there are not only positive urines, but there may be misses in attendance, when there might be relapse. And so we use expert case consultation, again, on site at the clinic. And we also used that monograph that I spoke about, recovery-oriented methadone maintenance, and not only distributed it, but really tried to have conversations that always focused around recovery, trying to take OTPs out of the harm reduction and into the whole mainstream of recovery. That was really how we started. The next things we did was also unusual. We surveyed clients on their treatment satisfaction and their perceived needs and their openness to changes in their treatment. Again, one of the fears was, wow, you're going to be asking people who come 2.5 hours a month to a weekly hour-and-a-half group. And that's the choices that was made, that there would be groups that started that would be an hour-and-a-half led by the same person. So we changed all these open thematic groups to ongoing CBT therapy groups. We worked intensively with a therapist who self-selected and helped assign clients to a group that met weekly, and the clients were also assigned to a primary counselor. So from 2.5 hours a month, they went to an hour-and-a-half group and what we hope is an hour individual therapy in the course of a week. All new clients were assessed for a level of care assignment within the OTP. The program was interested in offering at intake what became known as a phase 1 group. The program, Foundations calls it their enhanced counseling program. They were not ready to require everybody who needed a group to go to the group. They weren't ready to do that at the beginning of this project. So everyone was assessed and offered the opportunity for the group. There was a group of clients who were assessed and actually told this was what they needed to do. If you were relapsing, you were assessed for a level of care assignment. In the past, when there were relapses and it was not possible to adequately work with somebody at the OTP, they went outside the clinic, usually to a residential program, and they were pretty lost. So the plan was assessing all new people, offering them a level of care, they could turn it down, and assess relapsing clients and basically offer them the enhanced group or residential care. And we continued case consultation and process improvements. IRETA has worked for a number of years on process improvement and rapid cycle change, and helping people learn their data and learn how to use data to make changes in their own workspace. We use the classic PDSA model, Plan, Do, Study, Act. So we are on site, we're interacting with staff, and the groups are not just solo by the clinic staff. We're there as observers and debriefing afterwards. So this is kind of the structure that we did. The source of referral for these enhanced groups, these CBT groups, were patients who were new, relapsing methadone maintenance patients, surveying respondents who requested more services. And on the bottom, you'll see these are standards that are not ASAM. The level 1 outpatient is up to 5 hours per week. That is currently the standard in Pennsylvania. On July 1st, they'll be using ASAM criteria, and by ASAM, it's up to 9 hours of clinical services a week. Remember now, OTPs generally provide 2.5 hours a month. Level 2 outpatient is 5 to 9 hours per week. We have yet to install in the first site a level 2 outpatient, and there may not be enough clients, enough throughput to be able to do that right now. But this is the general outline of how it went in the first site, how clients were offered the enhanced services. So what you want to know right now is that these CBT groups are now in 2 phases. The first is for 12 weeks, and we worked with staff, but we designed a structured 12 weeks. It's not a manualized approach. It's as you're teaching CBT concepts, you're providing some content along the way. So we have, in fact, written 2 guides for phase 1, the first 12 weeks, and people that need more after that, phase 2. This on screen right now is what we have as our data analysis plan. You already heard that we took baseline measures, the retention rates of prior years. We took drug and alcohol use prior years, employment rates prior years, arrest rates while in treatment. These are outcomes that we're going to be able to match with national data, and if available, some state data for the state of Pennsylvania. And then we're going to do clinical matching. There's a clinical assessment. Who is matched to level 1 outpatient versus level 2 IOP. We're expecting to have improved retention, increased abstinence, improved employment, and decreased arrest, the things that you would expect. And the indicators are, an increase in days in treatment and abstinence and employment, and a decrease of arrests while in treatment. The reason we're expecting this and are going to look and are looking for it is the fact that people who were getting 2.5 hours a month are now getting 2.5 hours a week, and they're getting it in a recovery orientation, and they're getting it in a more focused way. So we have not outcome data because no one has actually left yet. We'll be doing this project, and it'll eventually become a multi-site study because we'll have 6 sites. So we don't have the outcomes yet, but we have in-treatment performance measures. And we have 42 people who have gone into the enhanced program between phase 1 and some of them into phase 2. Again, 12 weeks initial group, and those that need more move on into another 12-week group. So as of this month, out of the 42 referrals, we have 64% of them are still active, and 22% completed treatment. 7% went up to a higher level of care, and only 7% left. We're really happy with that, and the program is really happy with that. That stands in stark contrast to the dropout rate before. Completed treatment in this case doesn't mean they're out of the OTP. It means they've completed phase 1, the initial 12 weeks of group, and the follow-on phase 2 because they needed more and wanted more. So they got 24 weeks of CBT-focused group therapy. So here is something that's kind of unique. What we do after every group is hand out a survey to clients. It's a satisfaction survey. And right now, in phase 1, there had been 27 groups that had been held, and there were 152 surveys done, 37 unique clients. And the average size of the group is 6. Phase 2, there were 17 groups, and there's an overlap. There's some people who went to phase 1 and continued on to phase 2. And we have some results of the client surveys that are that were surprising. First of all, people really liked it. They found the group was supportive and helpful. And this was from a group of clients that people were concerned that they would come every week to a group for an hour and a half that met at the same time, and would come to individual therapy. The counselor was familiar with the topic. They strongly agreed. There's 152 survey results. I would recommend a friend to the group. We are very pleased about that. In fact, it's as strong a recommendation as we thought we would be able to get. I plan to continue with the group. It looks, again, like people have made a commitment. Again, the concern was that for people who had minimal attendance requirements, that upping this was going to drive them away, and they wouldn't do it. And in fact, that hasn't been the case at all. So these first results were from phase 1, the first 12 weeks. And then there was a group of people that continued on in group therapy. Same therapist, just some different content, and because they had the prior 12-week experience. Again, really positive. The group was supportive and helpful. The counselor knew what she or he was doing. I'd recommend it. I plan to continue with the group, which was really an important process for us. Now, along the way, we are collecting an awful lot of data here. One of the pieces that we do collect, and we will be able to follow up in, is not just attendance, but urine results, relapses. We're in a position to not yet completely have a data set that we're comfortable presenting, but things are moving in the direction that we expected. There are fewer relapses, and there are fewer relapses with opioids, and that is incredibly positive. This has been a group of clients and patients that have been very difficult to engage. And our harm reduction approach, which was well-intended, kind of didn't offer them a whole lot of hope. Some strong findings so far is that, yeah, you can do this. You can change from providing program-focused care to client-focused care. The clinic did not hire different staff to do CBT. Staff not only had the skills to do this and wanted to do it, they felt pretty constrained by the program design. They knew there was more that could be done, and more is being done by the same staff. The third thing to take away is you can do this change on site. It's labor intensive, but people respond just like they did in graduate school to coaching, to mentoring, to using their own material, their own cases to learn from. And it creates an optimism not just for clients, but also for staff. And that has been just a wonderful finding here. So we're now in our second site, a second clinic. We are doing the due diligence part of it. We're doing observations. We've collected data. We sit down with staff. We talk about cases. And we're going to be now beginning to teach and model how you would do a CBT-focused therapy group. Some of the language that we use now of enhanced program is language that came from the first site, the foundation site. So just in a really encapsulated summary, the reason that this is important right now is not just to make medication accessible to people with a severe opioid use disorder, but to also get them the clinical services that they need. That if they run into trouble while they're in an OTP, the clinic should be able to intensify services. They should be able to offer up to 9 hours of counseling services, a level 1 outpatient. And if someone needs a level 2 outpatient, they should be able to get it there. What happens now is when someone relapses consistently, they're out of the program. And a lot of them go and are detoxed from their medication before they go into an abstinence program. And that may be the right thing for particular patients, but it may not be the right thing for everybody. This gives programs a little bit more flexibility. From an administrative and financial standpoint, you need to have a payer who is willing to unbundle. In other words, set a rate for the medical services and then pay for clinical services based on the individual's treatment plan. So in this particular project, the payer, Southwest Behavioral Health Management, is paying for group therapy in the same way they pay for outpatient abstinence-oriented groups. They pay for individual therapy the same way. They would pay for a level 2 outpatient, which is not going to be put in right now with site number 1 until there's more of a throughput. So the payer was significant in making a business case, not just a clinical case, but a business case to these programs that, in fact, you will not only do a better job, but you're not going to lose money. You're actually going to be able to generate more revenue. And that is why we have 6 programs signed on board to be started over the next 3 years. So we'll be following this, and I think we'll be doing more webinars, and we'll be writing about results, more results as they come in. And I think at this point, I would say we're ready for any questions that you might have.
Thank you very much for the presentation so far, Dr. Luongo. Lots of good information. And yes, we do have a few questions already queued up. And for folks who might have a question that you haven't put yet in the chat or the Q&A, you still have time. Feel free to share your thoughts. And if we don't get to them, we will make sure that Dr. Luongo gets a copy of your question and he can get back to you. So, great. So to start off, we have, could you explain the, quote, elegance of using standardized treatment plans within recovery-oriented systems of care that, by definition, require individualization? While seemingly incompatible, how does your project manage the muddiness of individualization?
Well, my use of the term elegance is clearly tongue-in-cheek. It's elegant in that it can be replicated. It's not necessarily the best thing to do. It's the program-focused care. That's why I called it elegant. It's easy to replicate. And frankly, for large companies, it's a huge profit center as they've bought up independent methadone programs across the country and organized them into their for-profit companies. So it's elegant in that it's easy to understand and it's easy to set up and kind of easy to run. There's so much standardization. Now that is incompatible with an individualized approach. If medication is really a tool that helps stabilize and make someone available to participate in their treatment because they're now not going through the throes of a dependence and an addiction, and they're not being bounced around emotionally and socially and economically, you provide the medication and then you do the clinical services. You know, you do an assessment that decides whether they can be worked with in your clinic in a standard level 1 outpatient, which means a mix of individual, group therapy, and if necessary, couples and family therapy. Or would they be better suited to an intensive outpatient program where in the ASAM world, it's from 9 to 16 hours a week. People can be seen 3 or 4 times, 3 or 4 days a week. So it's not exactly murky. It's simply making it more like the rest of the substance use disorder treatment system and getting away from that program-focused care. Thank you for your question.
Okay, sorry, I was muted for a moment there. Questions are coming in fast, but the next one is, could you speak for a moment about pay-for-performance OTPs?
I can. I'd be delighted to. I
Wonderful.
haven't seen one yet. You could do it. You could do it based upon initiation and engagement and retention and status during treatment, but I have yet to see anybody do a pay for performance. It certainly can be done, but I haven't seen the outline of that yet. Thank you for your question.
All right, our next question is not actually a question. This is, I believe, a NIDA quote that one of our attendees wanted to share, and that is, regarding medication-assisted treatment, remember, medication is the hamburger helper, treatment is the beef.
Well said. Thank you.
Yeah, that was fun. All right, next question is, what is the reality of suggesting birth control and reproductive health information as part of the OTP accreditation process? Also, many thanks, very important and vital research.
I really can't address why accreditation requires that. I do think that is information that I would, as a responsible clinician, have available. On the other hand, I'm not quite sure it's something that you need to have in a didactic group. I think that might be something that I would want to be able to address as an individual therapist. But how accreditation standards were developed for OTPs, even though I was on the side of regulating the industry for a state, those accreditation standards are kind of a mystery. Thank you.
Next up, to what extent is titrating down or not being measured?
Well, we have that data available to us. And we just had a meeting internally with Dr. Lindsay, who is our Director of Research and Evaluation, to begin the design for a multi-site study and go through the approvals that we need to get. That is absolutely data that we get, but at this moment I won't be able to tell you more than that. That is something that we'll be able to look at because the data is very available. Thank you.
Thank you for sharing that answer. Now we have, can you please comment on your experience with individuals under court supervision and their being on methadone?
Okay, thank you for the question. Some of the work that we do now happens to be with problem-solving courts in the federal system. And we do quite a bit of explaining that a person who is being prescribed and using in the appropriate way medication is fine. You know, they shouldn't be excluded. I think there are ideological approaches in our behavioral health world as there are in the criminal justice system. So can a person be involved in the criminal justice system and being on medication? Yeah. The program that's treating, as well as, I guess, the local authorities, you know, need to be able to explain that criminal justice decisions are criminal justice decisions. Health decisions are supposed to be left to the healthcare people. And diagnosing from probation or diagnosing from the bench is something responsible jurists and probation officers don't do. I understand that there's ideological concerns. I am very familiar with some benches that are not interested in having anybody on medication-assisted treatment and consider that simply substituting one drug for another. And the difference between one addiction and another addiction in their mind is nothing. And of course, we're talking about medications that assist in care. So these are dicey times with the criminal justice system. I have been very fortunate in my career to be in both a county and a state that had very enlightened benches, and they left the healthcare decisions to the healthcare professionals, and we left the sentencing decisions, of course, as they're meant to be by the courts in the criminal justice system. Thank you. Very good question.
So our next question is, do you have any demographic information on the patients in the group and who appears to be doing well with this program?
Well, we actually do have some. We only presented a little bit here today. Most of the patients in this group, as I recall, females, and I can't tell you any more about it. The N is actually really small, right? There's been 42 referrals. And this is just sort of an update, but it's hardly the definitive piece. What we really found out of this, of course, is that, you know, you can do it. You can switch from program-based to client-based care. Clients will go to more intensive therapy and like it. And as it turns out, in this program, they're our best salespeople, or the best salespeople for the clinical staff, because they tell their fellow colleagues about it. But we do have that, but it's not enough of a sample to be able to make those kinds of outcomes. Stay tuned, there'll be more. Thank you.
All right, I'm gonna do just a couple more questions and then we're gonna wrap things up. Once again, if we don't get to your question, I'll make sure that it does still get passed along afterward. So our penultimate question is, could you please explain the spirit of the difference between a clinic being identified as an OTP versus an MMTP?
Yeah, I can. Thank you for the question. Originally, when all this was percolating through, and it was well over 18 years ago, the idea was to remove the medication from sort of being the star, you know, a methadone maintenance program, it doesn't actually talk a whole lot about the treatment end. So the thinking was that it would be another way to use language to emphasize that it's not organized around the medication to treat. It's organized around the disorder. So it's an opioid treatment program. It doesn't talk about the medication to treat it, methadone, as the way in which services are organized. So that's really the philosophical bent to that. And I think that's a healthy change. Thank you.
Thank you. We're going to have just one last question now, which is, what's your experience with participants using medical marijuana or CBD alongside or instead of methadone?
Oh, great question. Thank you. I don't have any. I know that's coming up. I've just downloaded and printed out some research articles that start to talk about that. Don't know enough about it to comment and haven't seen it. And again, this is just one site that we have right now. And I know in Pennsylvania, there are now medical marijuana dispensaries. There is also quite a push to we would like to see the research done so that we can have a better understanding of what compounds in the cannabis plant are the ones that make a difference. There's many compounds that are not psychoactive, like THC, and CBD is one of them. What are the compounds that have the greatest effect in pain relief or in suppressing nausea in patients who are getting chemotherapy or have AIDS wasting conditions? We need a lot more research. But no, I don't have any professional experience with patients. Thank you.
I'd like to thank all of our attendees today for your great questions and for just coming out and listening. And a big thank you to Dr. Luongo for such a great webinar.
Well, thank you.
You are welcome. At this time, I'm going to go over our evaluation and CEU instructions one more time, especially for those of you who didn't get to hear them at the beginning. You're going to be receiving a few emails from us following the webinar. The first email will include a link to both our evaluation and the CEU request option. You do have to go through the evaluation to get to the CEU request. Our evaluators are pleased to collect feedback from all event participants. Completion of this evaluation is critical to continue to provide quality education and materials. Your participation is much appreciated, and the evaluation should take no more than 2 minutes of your time. Immediately following the evaluation is a request form for a certificate of attendance or a NADAC CEU or a PCB CEU. Should you choose to skip the evaluation and proceed directly to the CEU request, leave all the answers blank on the evaluation. Once you've filled that out, certificates may take up to another 48 hours to appear on your web profile, so we ask for your patience. A second email will be sent to all registrants early next week, and that will include a link to a recording of this webinar, as well as a PDF version of Dr. Luongo's slides. We'd like to thank you one last time for your participation today. And if you have any questions, please email us at info@ireta.org. Thank you.